What patients say matters. How they say it might matter more. Today, I'm joined by Dr. Khozin, an oncologist, a computer scientist by training, a former FDA leader, and now the CEO of the CEO Roundtable and its data arm, Project Datasphere. The CEO Roundtable was founded by President George H.W. Bush and is a pre-competitive sandbox where biopharma and regulators tackle the problems no single company can. We had a long, meaty conversation, so we actually decided to break the podcast up into two parts. In part one, we get straight into the point of care, how ambient AI can restore the physician-patient bond and let us move past the confines of the EHR and focus on the full conversation in the room. Sean also explains why voice is a digital biomarker, how affect, cadence, and dynamic range reveal pain, mood, and even early neurological changes, and how these signals can be validated, regulated, and scaled far more consistently than human intuition alone. We also unpack Project Datasphere's blueprint for unlocking clinical data safely and what it means for oncology trials, tumor assessment, and the next generation of endpoints. If you build in healthcare or care about better cancer outcomes, this episode will change the way you think about measurement, documentation, and eventually what it actually means to care. Let's dive in. Hi, Dr. Khozin. Super nice to have you on the podcast today. Why don't we start by just starting with like an introduction? Can you describe give us a little bit of your story about, who you are, maybe what the CEO Roundtable is, and, what role, your organization plays in cancer care today?
Sure. Thank you, Matt. And thanks for having me on your podcast. You can call me Sean, by the way. So I'm an oncologist by training, but before med school, I was very heavily involved in computer science. So after med school, I ended up somewhat by accident doing a lot of work at the intersection of what today we call AI, biology, and technology, including a couple of companies that I had a chance to build around those themes. So currently, I'm the CEO of the CEO Roundtable on Cancer, and which is a very unique organization that I've been involved with for several years. I stepped into the role last year as a CEO. The organization was founded in 2001 by President H.W. Bush, and what he had in mind was to create a pre-competitive sandbox where all the biopharma CEOs could get together, put competition aside, and think about ideas and solutions that are bold and venturesome. Those were his words, and pre-competitive, things that individual companies and organizations are not able to do alone by themselves. So that was the birth of the Roundtable. He reached out to Bob Ingram, the late Bob Ingram, who was the CEO of GSK at the time, and he became the first founding chairman of the CEO Roundtable. And very quickly, other companies joined, and the rest, as they say, is history.
I really appreciate you sharing that, Sean. I think, you and I spent a lot of time talking about, your perspective of AI in medicine. And I think you have a really unique one, not only because of kind of where you sit in kind of the care stack, but also as your background. I don't know if you were expecting me to talk about this, but one of the really interesting things that I really enjoyed learning about was just your background and your passion for music. And I was wondering if you can just share a little bit about that, because I think it's relevant for, some of the topics we want to cover today.
Sure. Well, that was plan A, but I ended up going to med school. But kidding aside, I was drawn to music at a very early age. And I started to compose classical music in my teen years. And then when I was in high school, just like everyone else, I was in a rock band and started to get into jazz. And my thinking at the time was to continue doing music professionally as long as I can. And even when I went to med school, I was doing music on the side until the second year of medical school, when things started to get real and I didn't really have the time to perform. But, it's something that's very fundamental to who I am. And in fact, I've always seen a lot of parallels between music and medicine, especially when it comes to the harmonious nature of both domains. In music, obviously, there's harmony and there's tonality, which is the center of gravity. You know, you write a song in the key of X, and that's your center of gravity. The same thing applies in medicine, where the body has a center of gravity. Our physiology is such that there's always homeostasis. So that homeostasis is a center of gravity. And in fact, when I was in med school, we had a ensemble where we played for a lot of cancer patients that were admitted to our hospital. And out of that came the idea of starting to do a project as my thesis for med school, where I ended up quantifying heart sounds and breathing sounds, and started to write a composition based on essentially those waveforms. And the idea at the time was that anything that falls outside of the norm, meaning homeostasis, will show up as dissonance in the tonality once you translate these waveforms into musical notation. And that dissidence is pathology. So you can actually make predictions by following the waveforms. And once things start to essentially go outside the normal homeostasis parameters, then you can hear it as an atonal sound. And the thesis was that by doing so, you can predict transition states from like a healthy state to sickness, and sickness to eventual fatal event. So it was very interesting, and at the time there was not a lot of capacity to do any type of analytics on waveforms, because computational power was not as strong as it is today. But that translation into musical notation essentially compressed all of that data so that I could detect signals musically. And nowadays, you don't have to do that because we have massive computational power and a lot of amazing predictive tools. So that's how I, combined the music and medicine until the first few years after medical school. And now I have a one-person audience, my wife. So
two with me too.
All right. Well, thank you, Matt.
But I wanted to just make sure we share that part of the story, because when I met you, I was really moved by that part of your story, because I think it really resonated with me because I have this feeling that there's hidden value inside how people are saying things and not just what people are saying. And I think through our conversations, you have really enlightened me on, a lot of the research that's out there where they're focusing on just how people are saying things and what that might mean for cancer care specifically, and also, drug discovery, drug approvals, et cetera. And so, I was wondering if you can just share with us a little bit more just about how your perspective, what does this mean in the greater context of AI and healthcare?
That's a great question, Matt. And obviously, the context in which we express ourselves matters. So there are extrinsic and also intrinsic phenomena that can impact how you say things. And one of the conversations that we had recently is around when patients are telling the physician their story and their symptoms, the way they articulate those symptoms can be missed, because you have to really pay attention to their affect. And by doing that, you can pick up a lot of interesting information related to their mood, related to maybe the level of pain that they're having that they're not able to articulate or characterize accurately. And in my case, being a thoracic oncologist, I've picked up a lot of brain metastases on the phone just by talking to patients, because they haven't been the same. and they've just sounded different, and their affect has changed. So those signals are quite important. Physicians are obviously trained to look for those signals, and the more you see patients, the better you become at those. But at the end of the day, it's all based on your intuition and how much you can focus at the point of care when you're talking to the patient. So it's it may not be consistent, but the way that patients articulate their symptoms underneath that, beyond the semantics of what they're saying, there's a lot of valuable information that an experienced physician, and now I suppose a properly trained voice recognition model can certainly pick up.
Yeah. I mean, I think that's really, when we think about AI, I think so much of what we think about is how do we do the jobs today better, faster, cheaper. And I think ideas like this are really powerful, because it starts to show a world of care that we couldn't have even fathomed, or humans without this technology wouldn't be able to deliver. And so I think when I was looking at the work that you guys are doing at Project Datasphere, I think so much of that is just in that kind of camp of care that was previously unfathomable.
Mm-hmm.
And I think it would be interesting if, Sean, if you don't mind, just walking us through some of the other projects that you might be you guys are working on through
Sure.
Project Datasphere.
Yeah, absolutely, Matt. So Project Datasphere is a subsidiary of the CEO Roundtable on Cancer that was created in 2014. And that's how I, in fact, got involved with the CEO Roundtable, because at the time, the CEO Roundtable leadership came to the FDA, it was at the FDA at the time, to unveil their vision for Project Datasphere as a data analytics organization where, at a time, several member companies had committed data to the platform. So they came to the FDA to talk about the vision. And among those companies were Sanofi. It was Chris Viehbacher, who was the CEO of Sanofi at the time. He was really leading the effort and very committed to bringing data into Project Datasphere. So when they came to the FDA, all the data nerds like myself, we raised our hands to help. And Project Datasphere started to work very closely with the FDA, with the Oncology Center of Excellence as we know it today. So there's been a number of very interesting collaborations with Project Datasphere. And starting out, the platform was open access, which is quite radical. Companies brought in primarily control arm data, and that data was made available freely to anyone from around the world. A number of publications has emerged out of the open access data platform. One of the first things that Project Datasphere did was to do a dream challenge with IBM and also NCI and several other institutions. And that was a global crowdsourced challenge to use the data on Project Datasphere's platform and develop a new prognostic biomarker for prostate cancer. At the time, the leading prognostic model was called the Susan Halaby model, she's a very well-known GU oncologist. And Susan herself participated in this effort because she was quite intrigued to see if the crowdsourced effort using Project Datasphere data could surpass the accuracy and precision of her model. It was very interesting because the team that won was in the Netherlands, and a lot of folks that participated were not even in the life sciences. They were just folks, kids in the basement, for example, that just were computer nerds, if you will. There were a few quants in the hedge fund world that just liked to work with numbers, that they developed very interesting models. And again, the team that won had nothing to do with healthcare, and they were essentially quants in the Netherlands. So that, to me, this was 2015. I was at the FDA again at the time, but watching Project Datasphere very closely really revealed that data liquidity and access to data can be quite beneficial because there's so many things that you cannot even think about. And then you're also able to attract folks from outside the life sciences community And those perspectives matter because they folks that are not emerging from the life sciences have a different way of looking at things and thinking about, for example, prediction in different ways. We see that a lot, for example, in finance, how folks that are predicting the markets have very interesting tools in their toolbox that are often quite different than what we have access to in biomedicine. However, the ability to predict and the intent and the objectives can be the same. So that was quite an inflection point for Project Datasphere. And then following that, a number of other companies came, and then the NCI came, not just with control arm data, but also with experimental arm data. So the NCI essentially catalyzed the CEO Roundtable member companies to feel more comfortable bringing in not just the control arms, but also the experimental arms of the study. And, since 2014, there hasn't been any issues. A lot of what folks think about when it comes to data sharing, hasn't really been demonstrated, meaning a lot of the risk that people perceive, for example, threats to intellectual property. Our experience and the experience of other platforms, data sharing platforms, haven't demonstrated that it's really the risks that hold people back from sharing data are mostly perceived in general. But then Project Datasphere realized that open access is quite radical and it may not be appropriate for every data set because there are data sets, for example, large genomic data sets or imaging, DICOM images, not very easy to de-identify and share broadly in an open access format. So starting 2014, Project Datasphere started to launch pre-competitive efforts. These are closed access efforts where if there's an idea that can, or a challenge, a great challenge that can be solved with our member companies' data and support, then these pre-competitive efforts can accommodate that in a manner where the data is not shared broadly, it's closed access, and it's the intent is just to address those challenges with the data that the companies provide. And the first effort there was, in fact, a collaboration with the FDA after FDA recognized that two radiologists looking at the same image in registrational studies have a lot of disagreement, which made the FDA somewhat nervous. And they came to Project Datasphere asking Project Datasphere to collaborate with the FDA to develop an AI model to automate tumor dynamics and tumor assessment beyond the existing standard that we call RECIST. So that was the first pre-competitive effort of Project Datasphere, launched in 2019. And several companies came, brought data, and we've been developing AI models since then and have launched additional pre-competitive efforts.
Yeah. I mean, it's so amazing to hear because I think an environment like that in healthcare is so important because I think, in healthcare, we've talked about this before where in order to improve and innovate, you need to take on risk, right? You need to experiment. And, I think what Project Datasphere really allows is an environment where you can really kind of control that risk and experiment and figure out kind of new problems to solve and have the commitment around the table from, everybody to actually solve these problems for the greater good of healthcare. I think, one of the things that we talk about is like with the advent of ambient AI, I think for the first time ever, you have conversations of patient and provider interactions being recorded at scale. And, when we think about these foundational data sets of healthcare to help us understand what's happening in the room, how people are feeling, how therapies are working, how care is being delivered, it really provides this completely new, foundational data set to add to be able to observe how care is being delivered. And I'm curious if you can kind of share with the audience, what do you think we can do with that data? What do you think is unlocked in that information? And how do you think that impacts, a lot of the current processes and our current thinking of healthcare today?
Sure. Great question, Matt. And, I think maybe I'll preface my answer by sort of thinking back at how physicians used to practice medicine, before the advent of electronic health records and what we call managed care, where physicians could spend a lot of time with their patients. They even made house calls in some cases, and they really started to get to know their patients and how they articulate, their problems. Every patient is different, and they started to gain a lot of intuition about each individual patient, how they see the world, how compliant they may be with recommendations, and how they express themselves. So those were really interesting times in medicine because there was a very strong therapeutic bond between the doctor and the patient. Unfortunately, we've lost that because of several reasons. The volume of patients that physicians are seeing right now have been increasing, but more importantly, the documentation burden has exponentially increased in the past couple of decades. So that has had the unintended consequence of eroding the therapeutic bond between the doctor and the patient to the point that visits are very transactional. And you hear all the time, for example, from patients that when they see a doctor, the doctor is not even looking at them. They're just looking at the computer monitor and typing and just trying to listen at the same time. But that's not a very conducive environment for really understanding the patient and what they're saying. And the best that you can do is just to validate your own assumptions, which is not necessarily what a physician should be doing. You really want to go beyond your own assumptions and really extract new data points from the patient. So a lot of that, unfortunately, has been really a victim of electronic health records and the documentation burdens at the point of care. But ambient scribes, I think, are taking us in a way back to the time where physicians now have an opportunity to rebuild that relationship and to really start to understand their patient in a holistic manner. Now, what that really means is that the signals that one can get from these audio files are quite interesting and fascinating. At its most basic level, it can accommodate what we need to put in the electronic health records, which is frankly based on standards that try to create a framework so that you can put all the right data elements into the EHR. It's not holistic, it's actually quite reductionist. The first time you see a patient, that format, that template is called the history of present illness. And then after that, you have your SOAP note. And that essentially is your context window for capturing information, which is quite narrow. Even the history of present illness, which is quite tries to be comprehensive, is quite limited. And that's the way that I think about that is your context window for gathering information and referring back to that based on the information that you've gathered. But the context window in a recorded conversation between the doctor and patient is much, much larger. So we don't necessarily have to rely on what we think is necessary in terms of capturing data into the EHR. We can now go beyond that. So what are some of those parameters? I think we touched on one of those earlier, that the way that the patients speak, just the affect that would be reflected in how they express themselves. And in fact, if you even visually look at the audio file of audio waveforms, without AI, just if you just look at it for a patient that has a flat affect, it is actually quite flat because they don't have a very broad, what we call dynamic range. And that also exists in music, by the way. So it's quite interesting that a patient with a flat affect would not have a very broad dynamic range. The waveforms would be almost compressed. And AI can pick that up very easily and more. So that's one example where the signals can be used to go beyond what the clinician might be able to assess during the visit. But at the same time, there are a lot of things, a lot of stories, a lot of symptoms that patients talk about during the visit. You may not just pick up as a physician because, again, you have your own assumptions and you're trying to validate those assumptions and put in what's required in the electronic health record. So some of the things that the patients say may be missed, unfortunately. And ambient scribed, that record, that longitudinal record that would span several visits, can start to surface things that maybe the clinician wasn't paying attention to. So it's both the epistemic, the content of the conversations, but also the waveforms and how those waveforms manifest themselves and things that you can pick up as essentially digital biomarkers.
Yeah. And I think, we talked about this in some of our previous conversations about how, this reductive nature in medicine is, done for good reason, in the sense that you need to kind of abstract the data in a way for our current methodologies to analyze it to work, right? And so you have these common data models that might be taking, things that are, subtly different, but importantly different, but combining them into like one specific discrete definition. And I think what's really fascinating here is, as kind of computation and as AI is able to analyze things, more and more features, we're able to have kind of this completely new understanding of how patients are, progressing through their lives. You brought up a really interesting, thing at the last thing you said was around this digital biomarker. And, I think it's really interesting for us as an AI company to be able to, have the opportunity to collect these biomarkers through, at scale through the product that we've built. But, just really thinking about what that actually means for healthcare. Can you walk us through kind of like, how you believe these voice recordings or these digital biomarkers might serve as, novel surrogate endpoints for drug approval and for drug discovery?
Sure. A prime example is what we already talked about, being able to characterize in a reproducible way the patient's affect. And that should be quite relatively easy to pick up using just the audio files, the waveforms. And however, what that requires is to develop a system that is technically valid, measuring what it's supposed to measure, but also clinically meaningful. So it would have to be tested in the clinical setting prospectively. These are all things that are possible today. And based on our conversations before, it seems like, you are in fact working on a lot of these things. And then the FDA does have a mechanism to approve these digital biomarkers, whether through the software as medical device pathway or another pathway. The FDA has created a mechanism to advance these digital biomarkers into both the research domain, but also to the point of care. So it's quite very, very exciting because these are typically things that either only a very experienced physician can assess and pick up. So it's not consistent and it's not scalable. And even the same physician, depending on their mood, how tired they are, how many patients they've seen, perform very differently throughout the day. So these digital biomarkers can essentially democratize that clinical intuition and make it accessible and reproducible. So with very important, pain is another one of those things that we don't have a good way of measuring pain. Despite all of our tools and technologies, for anyone who's been to the ER, if if you've been asked what your level of pain is, they show you a happy face, sad face. There's an 11-point pain scale from 0 to 10. 0, no pain. 10, oh, it's really bad. And there's a picture of an emoji that's grimacing, basically. Well, we can do a lot better than that. And turns out that digital biomarkers can certainly play a role. Pain is reflected in the voice, how people speak. That's been a known fact for many, many years, but also in your facial features. And in fact, when I was at the National Cancer Institute, we launched a study where we start to offer a protocol to all of our patients where we use facial recognition to estimate their pain and mood. And actually, just a couple of days ago, I was talking to the PI of the study, Dr. James Gully, who's very well known in the world of immunotherapies. And that study is done, and the signals are quite strong, and he's preparing the manuscript for publication. So that's an example of a digital biomarker that can be applied today in the research setting. Obviously, the example I gave you with facial recognition hasn't gone through the regulatory pathway, so it cannot be used at the point of care, but that's just a matter of someone doing it. But I think everyone has an opportunity today, especially folks in drug development, because we do a lot of exploratory analyses and exploratory endpoints and biomarkers in every single protocol. So now there's a real opportunity to incorporate these digital biomarkers and validate them prospectively, starting with exploratory endpoints.
Yeah. I mean, every time I talk to you, I feel like I learned something new about a different way that we can kind of apply the information that we're gathering at DeepScribe, and it's really fascinating.
You're being too generous, Matt. Thank you. But there's so that's the digital biomarker piece, and we had also talked about the semantic content of the conversations. Again, things that the physician may not be able to remember or may not be directly relevant to the chief complaint. Just the fact that every visit has an official chief complaint, and you basically have to focus on that, tells you about the reductionist nature of how we engage with patients. Again, out of necessity, there's nothing wrong with that. In fact, it's served us well. But now we can be much more holistic, and that semantic content, once organized appropriately, can tell us about the patient's social situation. Maybe there were things that are in fact related to the chief complaint that the physician wasn't thinking about, that the patient expressed, and it was missed. So that semantic content, although that's not a digital biomarker, but these are data elements that can be very, very useful in treating patients and really to optimizing their care. And part of any quality care program, for example, going back to 20 years ago, is the idea that we need to collect more data than sort of that reductionist way of doing things. Unfortunately, none of these care quality frameworks have really been operationalized effectively because there's only so much data you can collect manually during each visit. And that also ties with pay for performance and sort of quality metrics. These quality metrics have been very tough to capture and measure because, again, there's only so much you can do in each visit. But now the semantic content of these conversations will have those data elements, for example, about social determinants of health, about patients' view of their own health and their preferences that are often not discussed early on in their treatment planning, especially for patients who have serious illnesses like cancer, where those preferences theoretically and technically should be part of the decision-making process.
Yeah. I mean, we talk so much about, at DeepScribe, we talk so much about how, sometimes it feels like healthcare is sometimes lost in like the science and the in the administration of care, and not really, it's losing touch with what it really means to care, right? And I think what's interesting about this wave of technology and, ambient really alleviating ourselves from the administration. It's really, opening up an opportunity for us to help with the science in the sense of it's providing, a new foundational set of data. It's able to help us synthesize and understand that data and surface the right data to make better decisions. But the most important thing is that I think it changes how we think about what it means to care for somebody, right? It's like, rather than having to do this reductive kind of process, right? Like, we finally have the time and to really look at somebody in the eye and tell them that they're going to be okay, right? And you bring up a really interesting point, because I always tell people during my mom's care with breast cancer, it's not always about the quantity of life, right? Some people care more about the quality of life, and it's very difficult to understand that and appreciate that and acknowledge that when you're so focused on writing a node that serves 16 different masters, from billing to the next physician to research, and everything of the like. And, I think this is a really, interesting opportunity, to humanize healthcare through technology, which is kind of like a paradox to say. Yeah.
Yeah, absolutely. That's a great point. And I like how you're looking at this. Quite insightful. You're in the trenches, Matt, and a lot of folks may not realize that physicians are so burdened with documentation, and that has been, in multiple studies, one of the primary factors leading to burnout, physician burnout, and you're essentially liberating them and decompressing them so that they can start to look at the patient and give them reassurance, or think about developing a more holistic treatment plan. So it's really strengthening the doctor-patient therapeutic bond, which is not only the right thing from an ethical perspective to do, but also there's been many studies that show that one of the most important factors in determining outcomes for a patient is really that therapeutic bond, and it manifests itself in different ways. Can you, for example, pick up the phone and call your physician, and would they answer immediately? Essentially, access to care. We have seen many studies quantifying access to care, and how challenges in accessing care can have very detrimental impact on outcomes. That's essentially what we're talking about here, that by decompressing physicians, we're creating access to care, because physicians can spend the time to maybe answer a few more emails, to answer a few more phone calls, and spend a few more minutes with the patient in the exam room. And this is something that fundamentally is part of the fabric of any physician. In fact, if you read sort of medical school essays, for admission, they are amazing. I think people are drawn to medicine because they want to help people. It's not a best profession for someone that wants to enrich themselves and make money. So everyone that goes into medicine, because it's such a substantial commitment, does it for the right reasons. Almost everyone. And one of the ways that I always measure that is by just reading med school essays. When I reflect back on my own, it's almost like a different person, because after you're exposed to the realities of medicine, all the documentation, things that have nothing to do with patient care, things that fall outside of that. And a lot of it is documentation and checking boxes. So let's automate the mechanics of the enterprise, so we can, in fact, go back to how we used to practice medicine, which is just about the doctor and the patient. And everything else is basically supposed to support that relationship. And, mathematically and technically speaking, that's all it is. All the supportive systems that we have in a hospital or in the outpatient setting is supposed to ensure that the needs of the patients are met, So you may make the argument that, well, we haven't made all the right steps in that direction. But now with AI, including ambient AI, we're on the path to automating the mechanics of the enterprise.